Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello and welcome to Triage. My name is Macy Flinchum and I'm an attorney in the firm's Research Triangle Park office, where my practice focuses on a variety of healthcare regulatory and transactional issues. Today, we're going to be talking about some of the major issues and key considerations for accountable care organizations, or ACOs, coming out of the recently proposed Medicare Physician Fee Schedule rule for the upcoming calendar year 2021, which was published by CMS on August 17th. CMS requested comments on its various proposals outlined in the proposed rule that were due Monday, October 5th. And if finalized as proposed, these changes would go into effect January 1, 2021. So today I have the pleasure of being joined by two of my healthcare colleagues to discuss the implications of some of these proposals. Limo Cherian, who is a partner in the firm's Chicago office, and Steve Pine, a partner in the RTP office. So welcome, Limo and Steve.
Thanks, Macy. Glad to be joining to be talking through the physician fee schedule changes for ACOs coming up.
Yeah, thanks so much, Macy. One of my favorite topics to talk about. And then there's obviously, a lot in the physician fee schedule, proposed rule, a lot that applies to Medicare shared savings programs. So we'll try today just to sort of hit on what we're seeing as some of the more key and interesting points, particularly, and where I'll start is with some of the changes to how quality measures are evaluated under the program. And so just to provide a little bit of background here to sort of put context on this. As folks might know, Medicare Shared Savings Program actually originated out of the Affordable Care Act. And these ACOs have been in place since, I believe, 2013. So we're talking 7 years of operation. And so since the genesis have had to report on quality and have had various changes throughout, but have always sort of had this quality regime that they've had to report on. In 2015, we had the passage of MACRA, and with that, the introduction of the Quality Payment Program, and as folks are familiar with, MIPS and advanced APMs, which measure clinicians on a variety of similar metrics under quality and under other categories. So ever since the Quality Payment Program has been introduced, there's been a bit of a disconnect in terms of how shared savings programs report quality and then how quality is handled for other of these alternative payment models. What this proposed rule will do is essentially harmonize them and drop into the shared savings program regulations this new APM performance pathway, or app, quality process that will replace how shared savings programs currently report on quality. Okay, so what is app, or the APM performance pathway? What it will do is winnow down the number of quality measures that an ACO has to report on from 23 currently down to just 6 measures. And so 3 of these 6 measures will be measures that have to be actively reported on, which will be diabetes and A1C control, preventative care screening for depression and follow-up plans, and control of high blood pressure. And then the other 3 measures will be the CAPS for MIPS patient survey measure, which currently is scored under 10 different measures, but that will now be combined into a single measure going forward. So that's the 4th. And then there will be 2 measures that are determined based on administrative claims. These are the unplanned readmission rate and the unplanned admission for multiple chronic conditions.
See, for the actively reported measures, that reduction to 3 was 10, I think, previously. Is that right, on the active reporting measures?
Correct. From 10 down to 3.
Well, that reduction from 10 to 3, I think that is, and again, the overall reduction from 23 to 6, the way that we're hearing stakeholders talk about this is that the reduction in the number of measures is probably something that is beneficial, to have a reduction in the total number of measures that are being provided. The flip side of that is that really puts a lot of importance on the specific measures that are selected and each one's relative importance. So then it's a question of, are these the right measures? So I think there's just a question about, are these the right measures for all ACOs, or is there a mechanism? The ACOs used to be able to select measures. Now they really can't do that, can they?
Well, that's right. And there is an exception for certain ACOs if they can show, and to be fair, CMS has not laid out exactly how this would work, but if they can show that these 3 actively reported measures aren't appropriate or applicable to their particular ACO, then they would have a mechanism to be able to select other measures. But to your broader point, Limo, I mean, I think that that's right. I mean, there's certainly a balance here where reducing down to 6 measures makes things more administratively straightforward, eases burden on ACOs in terms of what has to be reported, but it puts a lot more pressure on each measure, and it does sort of generate a question of, can you really look at a big picture in terms of how an ACO is providing quality just based on 6 measures? And so another important change here to consider as it relates to these quality measures is how ACOs are scored. And currently, an ACO has to meet a minimum percentile threshold of 30th percentile in order to sort of hit the minimum threshold that's necessary when we're talking about being eligible for shared savings. So one change that's occurring here is that 30th percentile is now being increased to having to meet 40th percentile across each of these 6 measures as it compares to all reported quality measures under the MIPS program. The other key change here is previously there was sort of a sliding scale in terms of the amount of shared savings an ACO might be eligible for based on how much they exceeded the minimum. Now, under the new rule, it really is a pass-fail where for shared savings, as long as you've hit the 40th percentile, you will be eligible for 100% of the shared savings that you qualify for based on your cost, and how that relates to the benchmark. That is not the case with shared losses, though, where shared losses going forward will still be on that sliding scale, similar to how they've been handled historically.
Steve, I think that's a curious policy decision in some respects. The 40th percentile was something that CMS had previously proposed. A lot of ACO commentators, stakeholders had responded previously that 40th percentile they thought was too high. And CMS's response generally has been and is now that ACOs are expected to be high performing. And so they thought that moving to the 40th percentile was actually appropriate for ACOs. So I guess part of the question is moving from 30 to 40, whether that's actually holding ACOs to a higher standard. But secondly, what's interesting is taking out sliding scale above the 40th percentile. If the idea is the ACOs are high performing, the question is then for higher performing ACOs, shouldn't that also give you a higher shared savings rate? So it's an interesting policy choice to say we're going to move up the base, but we're going to take away additional shared savings for people who are higher performing on quality.
Yeah, Limo, I completely agree. And it is interesting, also from the perspective of CMS talks about in the proposed rule that ACOs historically, haven't had trouble hitting that 30th percentile, and they don't expect ACOs to have trouble hitting the 40th percentile moving forward, estimating, 90+% of ACOs being able to hit that. But there is, I think, a question here, a broader question in terms of with the MIPS program, with CMS's focus on improving quality across the board, you wonder going forward in 2022, 2023, if there's continued improvements in quality across the board, and as we move from 30th percentile to 40th percentile, are we eventually going to be at 50th percentile? Is it a fair expectation that ACOs are going to be able to continuously be above average on all of the quality measures as compared to the broader population? And historically that hasn't been a hard hurdle to cross, but in the future that might be increasingly difficult.
And Macy, I don't know if you want to address one of the measures here is patient experience, the patient survey, and having that be of the 6 measures put some pressure on ACOs.
Absolutely. There's a concern here about patient responsiveness to these surveys generally. Based on the sample size here, this measure could significantly skew results for ACOs.
So it'll be interesting to see how these 6 end up working in practice.
Absolutely. Another consequence of moving to the new APP scoring approach is that it would effectively eliminate the initial pay for reporting year that's currently provided to ACOs during their first performance year of their initial contract, or for any measures that are new or substantially revised by CMS. So as it's currently structured, as long as ACOs submit data for quality measures, they are eligible for savings in their first year of their initial contract or for any new measures. And if this change is finalized, new ACOs would be expected to meet that expected 30th percentile target, which, as Steve notes, will now be a 40th percentile target in their very first year. And if they fall short, no shared savings would be achieved at all.
I don't think we can underestimate the importance of this proposed change. I mean, what we're basically saying, what CMS is saying here is that for an ACO that begins on January 1st, that for that first year, that ACO has to hit the 40th percentile in each of these 6 measures in order to be eligible for shared savings. That is a very big lift for a startup ACO to be able to achieve in its first year. And especially as they're really just getting their operations up and running. I think that is a really big question in terms of whether that means that any first-year ACOs can actually achieve shared savings. Again, it involves a lot of logistics to be able to get achieving those quality benchmarks starting from day one.
Yeah, I absolutely agree with that, Limo. And not only for new ACOs, but for existing ACOs, as we see changes to these quality measures or the introduction of new quality measures, of course, that existing ACOs aren't going to get the first year benefit of pay for reporting for new measures either. And so you may have situations, when additional measures come along down the road, like the healthy at home measure that CMS talks about might be introduced in a future year, there may not be a lot of runway between really understanding the methodology and how to achieve quality under that measure and actually being scored based on your performance.
Another key change that CMS is proposing related to reporting requirements is the total elimination of the CMS web interface for all ACOs and MIPS reporters beginning with the 2021 performance year, which is a change that CMS at least attributes to the low uptake of use outside of the ACO program. So with the web interface eliminated, ACOs would report on quality measures in either one of two ways. They're using a registry or directly through their EHRs using electronic clinical quality measure standards. And again, with many of the measures we're discussing today, this change would be effective for providers beginning January 2021. I think several stakeholders have noted here that just the abrupt elimination of the web interface, which is a tool that's been utilized since the MSSP's inception, would have a disproportionate effect on ACOs in particular and would cost significant time, money, effort to implement. Just operationally, ACOs would need to account for additional fees to pay for registries or adapt current EHRs to comply with the ECQM standards. So while I think many stakeholders have supported a gradual move to more automated reporting in the future, an abrupt change like this to lose the web interface for the upcoming performance year could create a significant hardship for ACOs.
Macy, completely agree with that assessment. I think that part of the issue is they're not necessarily group practices that have their own EHR. So the ACO is going to have to get technology in place and then actually change the reporting mechanism that they've used for many years. That, I think, is something certainly makes sense to not have a separate system only for ACOs, but the transition to that will require implementation, and technology implementation is not rapid among generally ACOs that are groups of providers that span independent providers, hospitals, health systems. Again, trying to do this in a way that can meet a reporting deadline that's this soon is a technological hurdle, and I think it is going to pose some problems for ACOs.
And there is kind of an interesting disconnect in the proposed rule where, on the one hand, with the MIPS value pathways, which we haven't really talked about, but was something that was proposed last year in last year's final rule, those are being postponed until 2022 because of concerns related to COVID. Yet, on the other hand, a lot of these changes for the Medicare Savings Program, will go into effect starting in 2021. So it's been interesting that they've sort of taken different approaches there as between MIPS versus the Shared Savings Program.
Macy and Steve, there's one more thing I'd like to talk about before we finish today, and that's specifically regarding timing. Comments to the physician fee schedule were due earlier this week on Monday. So I'm just going to say the implementation of all of this is really fast in terms of a January 1st start date.
It's a lot, and it's under a really short time frame. We're talking less than 3 months at this point from when some of these changes would go live. But of course, we don't have even the final rule yet to know if this is the final form that these changes will take place as. And we don't exactly know when we're going to get the final rule, considering this is a many hundreds of pages proposed rule with 20-some thousand comments. So yeah, it's a quick turnaround.
It seems also strange to be able to be thinking about making these massive changes during 2020 for the 2021 year, given the changes in healthcare that have been happening over the past year with the COVID-19 pandemic. ACOs are dealing with a lot of things, and this is just one, well, it's not one, it's a lot more things that they're going to be dealing with in 2021, which again, in terms of where we stand in terms of healthcare delivery related to the COVID-19 pandemic, I don't think there's anyone that doesn't think that this is going to continue to have impact into 2021.
Well, I think that's about all the time we have today. Thank you to Limo and Steve for joining me, and we'll look forward to talking with you again soon.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.